David, and good evening, everybody. I have to introduce quite a few things these days, and usually on subjects I know nothing about, but in this case I think I have some competence in the area, and so it's really a great pleasure to to help with the launch of this report on evidence for action on HIV treatment and care systems. And it's an impressive piece of work on what is sounds like a very simple issue, but it's actually an incredibly complex challenge, but also where, against all odds, we've made enormous progress. And therefore it will remain very important to document what is going on, the problems, the mistakes we've been making collectively, and also document, as was the case, as what I learned from this report, also the very specific situations in each country. Even neighboring countries can sometimes have very contrasting challenges and results, and be successful or not for very different reasons. And understanding that, I think, is really important to inform policy. The school has a long history of DFID-funded health research programs, and Evidence for Action is one of them. I think now there are 9 total. Some are new ones of these DFID-funded research program consortia, and this has been going on the past 6 years. And they're not only important in terms of the product, such as this is one product, but also the dynamics that it creates and the synergy in terms of the various partners working together and learning from each other. I think it's fair to say that nobody is rich enough to not learn from those, and nobody's poor enough not to have something to share. This Evidence for Action research program began in 2006, understand, and since then the AIDS landscape has changed quite fundamentally. Some for good and some is cause for worry. When the project started, I think there were like 2 million and a bit people on antiretroviral therapy in low and middle income countries. Today, probably around 6 million, although there are no official figures yet. The latest figures are for the end of 2009. But that is absolutely remarkable progress, and it's not just statistics. These are lives. People are still alive who, most of them, I think it's very safe to say, would have died in the meantime. And that's not only important for these 6 million individuals, but their families, their loved ones, their communities, and even the productivity in their community. So that's a really great progress. And achieving universal access to antiretroviral therapy, as was agreed in the UN General Assembly, I think in 2005, I can't remember, is really important for many reasons. First of all, of course, for the individuals concerned, it's a matter of survival. It's as simple as that, and that should actually be sufficient as far as I'm concerned. But also, it is the best way of preventing mother-to-child transmission. So you prevent HIV infection in babies, in children. Quality of life. We've got good examples of people who could start a business, continue to work, and so on, and that quality of life. And the fourth, I think particularly after the results that were announced last week from a mega study, a multi-country study on the benefit of treatment for prevention in discordant couples, where there was a reduction of, I think, 97%? 96, thank you. 96% of the risk of transmission, which is spectacular. I think it's a bit early to make a claim that this would be the same in a population level. I think that requires definitely some more research, and there is some proposal from the school here together with colleagues in Malawi and in Zambia and elsewhere, in Imperial College and so on, to study that at the community level. But all this points to the fact that administering and providing antiretroviral therapy is far more than an act of just providing a few pills. It has a fantastic impact in the community, and this is what this report is also about. So it is important that we document what's going on, that we learn from all the problems, that we also take a long-term view, because one of the challenges, I think, is that with programs such as the Global Fund and PEPFAR, that the performance indicator is how many new people did you put on antiretroviral therapy. Now, that is a good start, but as we all know, it's for life. And so we need better monitoring, we need better systems for treatment compliance, for long-term treatment, and that has enormous challenges. And I think that's, in a sense, the big agenda of today, taking this long-term view, and that goes from the price of second-line treatment. A country like Brazil, which was the first middle-income country to offer treatment, antiretroviral therapy free of charge to its citizens, the price of drugs, of antiretrovirals, has doubled already around 2005, because even if it was a minority, but because so many people needed second-line drugs which are not available generically, or are simply far more expensive to produce. So the research results in this report really add to the evidence on how to best deliver antiretroviral treatment. And what is interesting is that it is trying to integrate those, to see how can it be integrated in the regular system, in peripheral health services, an evolution that we've seen in many countries in the world, including in Europe, where now in most countries it's a general practitioner who is really taking care of people living with HIV after some checkup or when there are complications in a more specialized center. So the reports, I think that the results are highly relevant for ministries of health, national AIDS commissions, international organizations, all kind, bilateral, multilateral, but also groups of people living with HIV who, after all, it's about their lives. So congratulations, David, and your whole team. I know this is an effort of many people, far more than this room even could contain, and I'm looking forward particularly to see how the findings and experience will be taken up by policymakers and by implementers in the most affected countries. So again, my best